Well, good evening, everyone. My name is David Sullivan from the Department of Clinical Biochemistry at Royal Prince Alfred Hospital in Sydney, and it's my pleasure to participate in this LabRoots webinar. It's morning here in Sydney, Australia, but I gather it's the end of a long day for most of you who've been participating. So thank you for your patience and participating in this particular webinar, which is entitled Opportunities to Simplify Clinical Lipid Assessment. And the object of this particular webinar will be to look at both our routine and our non-routine lipid testing, because there are changes occurring which I think bring with them the opportunity to have a simplified yet more effective approach, and we'll try to look at that in a coordinated sort of a way. So what I'm going to do is to think about routine lipid and lipoprotein testing, sorts of things such as measurement of total cholesterol, fasting triglyceride, HDL cholesterol, and the calculation of LDL cholesterol according to the Friedewald equation, and try to interface that with some changes in advice in those fields and how it may let us better utilize some of the non-routine testing, those aspects such as testing of apolipoproteins, the use of electrophoretic techniques, and moving on to fields such as genotyping and miscellaneous techniques such as gas chromatography, mass spectrometry, etc. And we will then think about how we use these tests and how we and how they can be better utilised for patient assessment. If we ask ourselves the question, what are the modifiable risk factors that affect cardiovascular disease, some interesting information has been derived from a large-scale study called the Interheart study, looking at the case-control causes of myocardial infarction, not only in Western countries but also in emerging economies. And the results of that study, you can see, demonstrated the relevance of the classical cardiovascular risk factors, things like diabetes, hypertension, smoking, etc. And you'll see the top of the list there was the so-called ApoB to ApoA1 ratio. And in this trial, that was the means by which it was attempted to assess the lipid status of the participants, and it was trying to capture both the atherogenic and the anti-atherogenic aspects of the lipoprotein profile, and apolipoprotein measurement was chosen in an attempt to accommodate non-fasting samples. And you can see that this topped the list in terms of the odds ratio, the attributable risk, and it also topped the odds ratio, and it also topped the list of the population attributable risk, and it was contributing in nearly 50% of cases. This was largely because it was felt that around about 80% of the participants had non-ideal lipid profiles, so it was a very major contributor. The other interesting thing from this trial was that below the line you see for the first time statistical evidence about the contribution of things we've suspected as risk factors but haven't been able to prove in the past. Things like abdominal obesity, psychosocial factors, poor diet, lack of exercise, and a slight beneficial effect from alcohol. But the main message from this slide was the prominence of lipid risk factors, and just interestingly, the use of apolipoprotein measurements in this epidemiological study to try to capture that. So we try to approach each individual patient with a standardized sort of an approach which would allow us to calculate their absolute risk of a cardiovascular event in the next 5 years. And so first of all we see, if I can get the arrow to point, first of all we try to assess the patient's non-modifiable risk factors, their gender, age, maybe ethnicity, etc. Next we try to capture clinical modifiers of their overall situation, things like whether they've got cardiovascular disease, renal disease, diabetes, etc. We then introduce the modifiable risk factors, their blood pressure, whether they're smoking or not, etc. And then the lipid component is also incorporated, particularly in terms of their total and HDL cholesterol. And with these aspects, it's possible to calculate the absolute risk of an event in the next 5 years. And this, of course, can then generate appropriate management plans. Those management plans might start with additional measurements that need to be made. And it's worthwhile stressing that if the risk is in an intermediate zone, it's at this particular point that additional measurements, whether they be additional lipoprotein measurements or other risk assessment measurements such as C-reactive protein, etc., that they might contribute to that process. And out of all of this information, a decision can be made as to which particular treatments are appropriate for that individual patient. And so an important part of this process is measurement of total cholesterol, which will usually be modified with the addition of information about triglyceride and HDL cholesterol to generate the Friedewald equation derived LDL cholesterol level. And so this is based on the assumption that if we have a fasting sample, there won't be any chylomicrons present. You would point out, of course, that chylomicrons are fairly poor in cholesterol, and so that shouldn't make that much difference, but it helps with the logic of the Friedewald equation, because we can then assume that the total cholesterol is made up of the combination of the cholesterol in very low-density lipoproteins, plus that in low-density lipoproteins, plus that in high-density lipoproteins, the first two being atherogenic and the latter being anti-atherogenic. We can then rearrange that equation so as to say that the LDL cholesterol on the right-hand side is going to be equal to the total cholesterol minus the VLDL cholesterol minus the HDL cholesterol. If we then make assumptions as to the composition of VLDL particles, then for non-SI units, we divide the triglyceride by 5, or for SI units, divide the triglyceride by 2.2 to derive the appropriate Friedewald equation that the LDL cholesterol equals the total cholesterol minus the HDL cholesterol minus the triglyceride divided by 5, or 2.2 in milligrams per deciliter or millimoles per litre, respectively. And several conclusions are actually evident from this approach. First of all, it should be evident that total cholesterol alone, when studied in isolation, is inadequate for assessing cardiovascular risk because it contains both atherogenic and anti-atherogenic lipoproteins simultaneously. The second point is that when triglyceride is elevated, it does place limitations upon the Friedewald equation. We may be running into a situation where triglyceride-rich lipoproteins with different composition are present, maybe chylomicrons or remnant particles, and this would invalidate the Friedewald equation. And it's also a useful reminder that when triglyceride is elevated, there tends to be a reciprocal relationship. We should check that this is the case. A reciprocal relationship, high triglyceride tends to be associated with low HDL, and as we'll see in later slides, there are implications for the composition of LDL particles themselves, which may not be so well captured by the result of the calculation, the LDL cholesterol itself. And finally, and I'll illustrate this in the next slide, there are some new therapeutic developments occurring which may confound this Friedewald calculation of LDL cholesterol. And that's illustrated on this slide here. First of all, in the left-hand panel, you can see some very low LDL cholesterol levels that are achieved with the new anti-PCSK9 antibody therapies for cholesterol reduction. Here we're getting down to LDL cholesterol levels well below 40 milligrams per deciliter, well below 1 millimole per litre. And you can see that as you get down to these levels, the correlation between calculated Friedewald LDL cholesterol and gold standard ultracentrifugationally directly measured LDL cholesterol is disconcertingly poor, with really very unacceptable levels of agreement. and of course with the Friedewald being the comparator against the gold standard, the suggestion is that the formula is not performing well under those circumstances. In the right-hand two panels you'll also see what happens when we use a different class of drugs known as cholesterol ester transfer protein inhibitors. First of all, you can see a very substantial change in LDL cholesterol level and a really quite astounding more than 100% change in HDL cholesterol level. As you'll see in the next slide, this occurs because of changes in physiology which will alter the composition of most lipoproteins, particularly the triglyceride-rich lipoproteins, and so our assumptions which underpin the Friedewald equation may well be undermined, and patients receiving this sort of treatment would not be suitable for Friedewald equation LDL. And in fact, when used in trials, the Friedewald equation was starting to generate negative values for LDL cholesterol, etc. So obviously inappropriate in those patients. And here you see the basis of the action of cholesterol ester transfer protein. I'll just quickly highlight its presence here. So cholesterol ester transfer protein is responsible for the manner in which cholesterol can, and lipids in the core of lipoproteins can exchange down concentration pathways. So we have triglyceride-rich lipoproteins, which will lose triglyceride but have it replaced with cholesterol from cholesterol-rich lipoproteins, and in the process the triglyceride-rich lipoproteins will become cholesterol-enriched. But more importantly, as we'll see in following slides, the triglyceride in the cholesterol-rich lipoproteins such as LDL will be catabolized as fuel and will lead to shrinkage and decrease in diameter in those cholesterol-rich particles, thereby altering their composition, density, etc. And so the general rule is that when triglyceride is elevated, LDL cholesterol may underestimate the number of particles present, and the risk of cardiovascular disease is probably driven more by the number of particles than it is by the absolute amount of cholesterol. And this is illustrated in the Quebec Heart Study. It illustrates the measurement of so-called small dense LDL, which people are, I think, now familiar with as a more atherogenic form of LDL. However, you can see in the orange bars that when the LDL are small and dense, they do not constitute an increase in cardiovascular risk unless they are increased in numbers. The blue bars show you the situation in which the number of particles are increased, and so there is an increase in risk both in small dense and in normal composition LDL particles, about a twofold increase in risk. However, the most exaggerated increase in risk occurs when there is both an increase in LDL particle where there is a decrease in LDL particle size, small dense LDL are present, but they are present in increased numbers, and you can see that that constitutes nearly a six-fold increase in risk. And so small dense LDL are only dangerous if there are too many of them. The assumption behind the ability to assess the number of particles here is that there is one ApoB molecule per atherogenic lipoprotein. So Apolipoprotein B is a good method for counting the number of particles. The main alternative that we have for counting the number of LDL particles consists of an NMR spectroscopy method, and one should consider non-HDL cholesterol as possibly a practical means by which we can approximate these more sophisticated measures of LDL particle number. And one of the consequences of this is if we use ApoB as a comparator, if you like a gold standard for assessing the number of LDL particles, we can look at the degree to which different derived calculations can approximate that measurement. And if we first of all look at LDL cholesterol, our usual marker of atherogenicity, we see that although there's good correlation on the left-hand side, the degree of concordance is rather disappointing at only around about 50%, and it is in fact surpassed by a much simpler measurement, the measurement of non-HDL cholesterol, simply the difference between total and HDL cholesterol, and that the correlation is better, and indeed the degree of concordance is better, with nearly a 2-to-1 ratio in terms of favourable agreement versus discordance. And we are now familiar with evidence that suggests that when we take these different measures of atherogenicity, we get different results. And so if we look at the effect of LDL-lowering therapies, you'll see that the amount of reduction differs according to whether we've measured LDL cholesterol, non-HDL cholesterol, or ApoB, a more flattering sort of a result for LDL cholesterol than for the other parameters. Likewise, if we include measurement of particle number by NMR, again, a less flattering figure again. So if we want to approach the proper assessment of our interventions, we probably need to use these measurements which are more directed towards LDL particle number. And we see this again in assessment of risk, in this case from the US Health Professional Study. We see that the hazard ratio, the risk ratio, was greater for non-HDL cholesterol and for ApoB than it was for LDL cholesterol. And in prospective studies from the Framingham Offspring study, we can again get an indication of the superiority of particle number in comparison to LDL cholesterol. In the yellow lines, you see where there's agreement. So we have a yellow line of better survival in patients who had both a low LDL cholesterol and a low LDL particle number, worse survival in those with a high LDL cholesterol and a high particle number, so that's where there is concordance. But where the results were discordant, you'll see that particle number was superior, that we had better survival in those patients who had a low LDL particle number despite having a high LDL cholesterol, and worse survival in those who had a high LDL particle number despite having a low LDL cholesterol number. So again, just pointing to the superiority of LDL particle number over LDL cholesterol. If we turn to the next component of our routine assessments, the HDL cholesterol, there are a couple of conceptual issues here. First of all, there is the possibility clinically of having patients with high HDL cholesterol levels, and of course that would confound the assumption that anyone with a high cholesterol has a high level of risk. There are quite a number of these patients. Often older female patients will have very high HDL levels as part of a high total cholesterol. But at the same time, we're also starting to see the emergence of a bit of a debate as to whether all HDL is good. And so it may not necessarily be the case that we can rely on the ratio between total and HDL cholesterol to assume a lack of atherogenicity. It may well be that HDL varies in its functionality. I think this is still open to debate. This is largely the product of the results from some of the trials with cholesterol ester transfer protein inhibitors, where the expected cardiovascular disease benefit was not achieved. However, that has to some degree been thought to be due to the lack of the presence of off-target effects as far as the individual drugs were concerned. So, thinking more particularly about the measurement aspects of HDL cholesterol, we do have a basic reference method, which was the precipitation of ApoB containing lipoproteins with dextran sulfate magnesium. However, we've moved to so-called direct methods, which have been validated against the reference, against the designated comparator method, and they've been through a number of different iterations. The early assays had quite a few reagents and complex procedures, and eventually required simplification. Came down to using a smaller number of reagents, often involving alpha-cyclodextrin, and there was an improvement in HDL performance based on the fact that these methods were automated rather than semi-automated, and therefore more reproducible. However, they all hinged on the concept that what was happening was that the reagents were leading to a selective availability of only HDL cholesterol for measurement by the particular analytes. And so a lot of this depends on the actual selectivity of the methods themselves. And this is seen on this particular slide, but the concept is that the reagents coat both the lipoproteins and the cholesterol esterase and the cholesterol oxidase, and they prevent interaction between the reagents and LDL and VLDL particles, but leave it accessible to the black dots, namely the HDL particles. However, this selectivity is not absolute, and as the package insert explains, there is no model available that can mimic interference by triglycerides, and triglyceride levels in patient specimens behave unpredictably. In our experience, this has led to a phenomenon where the assays that were common in the mid-2000s, they may have been updated since then, but at that stage there was a demonstrable interference with the direct HDL methods via triglyceride-rich lipoproteins. It was evident that there was reduced HDL recovery in hypertriglyceridemia, suggesting positive interference, and that could mask low HDL in cases of hypertriglyceridemia. It was slightly abolished when the alpha-cyclodextrin methods were reintroduced, but subsequent reformulations of the assay may well have got around this problem to a large degree. However, it's worth cautioning that most external QC samples are spiked with concentrations containing all lipoproteins, and so the usual inverse relationship between triglyceride-rich lipoproteins and HDL is not evident, because they are increased in parallel in the quality assurance samples, and therefore the interference may not be evident. If we think about our next standard or routine laboratory lipid assessment, that would be the measurement of triglyceride. Here there are a couple of principles to keep in mind about the assay. Of course, fatty acids which might be present in triglyceride can vary in molecular weight, and therefore they may not be suitable for the standardization of the assay. However, the glycerol backbone, there is one molecule per triglyceride molecule, and that would be a more suitable target for the assay techniques. However, it needs to be remembered that there are other glycerol-based biological lipids, most particularly phospholipids, and so as we perform the assay, we are making assumptions. We're measuring the glycerol, but we're making assumptions about the relative lack of endogenous glycerol, and we're also making assumptions about the generation of glycerol via a lipase and its specificity for triglyceride as compared to lecithin. But the more important issue, I think, as far as triglyceride measurement is concerned, is the question of the need for a 12-hour fast prior to measurement. This is a component of standardization of the assay. It avoids the presence of chylomicrons, which, as we've seen, is an assumption from the Friedewald equation. And, of course, it standardizes triglyceride against the presence of dietary triglyceride for the measurement of triglyceride for the diagnosis of hypertriglyceridemia. So we've reached a stage, however, where it seems that there might actually be some advantages from measuring non-fasting triglyceride. First of all, it seems to be more sensitive as a marker of cardiovascular risk and even as a marker of total mortality. Also, you can make the point that it doesn't, the failure to fast does not have a huge impact on total or LDL or non-HDL cholesterol, although it does have a modest impact on HDL cholesterol. And this slide illustrates for you the superiority of non-fasting as compared to fasting triglyceride levels for the assessment of risk of myocardial infarction, cardiovascular disease and total mortality in men and women. As you see, the increasing risk across quintiles, and the most effective measurements tend to be those which were taken about 4 hours after the previous meal. And so if we try to weigh up the pros and cons of postprandial measurement, could we ever standardise measurements that actually tested us in the non-fasting state? We'd have to think about the composition of the food and the amount that was given. We'd have to think about whether that was physiological in terms of comparison to what we eat on a daily basis, whether there was a contribution from the diet in the hours or days beforehand, whether there was modification according to gastric emptying time, which might vary with different foods. There'd be questions about what to measure and when to measure it, and there'd be also the question of how to present the data, which particular time points, would there be a combination of time points. In many ways, it's becoming rather equivalent to a glucose tolerance test. And probably the main interest is in the specificity of markers of the postprandial state, measurement of the specific apolipoprotein B48 or of the marker retinyl ester. However, it may be worthwhile pursuing these particular objectives because it may well be that the postprandial state is more atherogenic and that we're only going to appreciate that if we study non-fasting samples. This atherogenicity may have to do with the flux of dietary cholesterol. It may be influenced by competition for LDL receptor clearance. We're familiar that dietary particles probably activate factor 7 and the coagulation cascades. We would think about the role of chylomicron remnants in the actual formation of plaque, and we're familiar with quite substantial changes in vascular reactivity that may occur in the postprandial state. So as we try to weigh up the pros and cons, I think we have to preserve a role for fasting measurement because otherwise the test of triglyceride is unstandardized in terms of its details, and therefore we do require a fasting sample if we're going to be calculating LDL cholesterol via the Friedwald equation, or if we're going to be attempting to diagnose or monitor hypertriglyceridemia. However, there may be a lot of situations where we are using fasting samples at the moment where a non-fasting sample may be completely adequate. For instance, it would appear to be adequate to supply a total and HDL cholesterol level for inclusion in risk calculators. Secondly, it should be adequate for the calculation of non-HDL cholesterol, and as we've seen, that non-HDL cholesterol is superior to LDL cholesterol for risk calculation, and therefore it is likely as we move to a greater use of non-HDL cholesterol that we should be familiar with the sort of conversion. For the most part, a non-HDL cholesterol target will be around about 0.8 millimoles per litre higher than an LDL, the current LDL cholesterol targets. I'm sorry that this slide looks like it's distorted a little bit, but having dealt with the routine tests, I'd now like to spend a little bit of time thinking about the non-routine tests and how they would interface with the changes that we've mentioned so far. We've already pointed out that in the Interheart study, the ApoB to ApoA1 measurements were used as an attempt to compensate for non-fasting measurement of the patients. And I think there could be a debate about whether that was necessary. We've seen that maybe we can measure lipids non-fasting as well, and whether apolipoproteins offer any ability to get around the non-fasting state, I think is a little bit open to debate. We've already discussed the superiority of ApoB over LDL cholesterol. The question as to whether ratios of any sort are superior to one over the other, I think, is also debatable. They do make the assumptions about the protective nature of HDL and ApoA1, which I've said is under question. And I think the role of ratios has really been an epidemiological convenience of combining two separate independent risk factors simultaneously, and the advantages of doing that, I think, may not be so significant as we first thought. There is a clear role, I think, for the use of ApoB based on its superiority over LDL cholesterol, but we'll look at the issues for ApoA1 in a minute, and I think there's less evidence for the need to separately measure ApoA1. And amongst the other routine apolipoproteins, and I'm sorry that their function may be a bit blurred here on the screen, apart from the ApoB, the main other apolipoprotein which may come to have a diagnostic role is ApoC3 measurement, which has quite a close association with triglyceride levels. We said that we'd look separately at the potential for superiority of ApoA1 over HDL. That's been looked at in a number of studies, and really the results have been mixed, that in some of those studies HDL cholesterol has been superior to ApoA1, and there's nearly equal number of studies in which ApoA1 has been superior to HDL. So I think the conclusion that there isn't a strong case for ApoA1 being superior to HDL, therefore a question as to whether its separate measurement is justified. One apolipoprotein which would appear to be of major diagnostic significance is lipoprotein a, abbreviated sometimes to LP-a, and its main distinguishing feature is that it is an LDL particle to which the unique apolipoprotein known as apolipoprotein A is attached. And so being based on an LDL, of course it contains ApoB, but in addition there is this covalently linked ApoA, leading to the LP-a particle. The ApoA molecule is genetically polymorphic. It varies greatly in the number of Kringle 4 type 2 repeats. And of course this polymorphism, like we saw for triglyceride and fatty acids, this polymorphism has major implications for the standardization of measurement. The other thing about the ApoA molecule is that it has sequence homology to plasminogen, and is therefore likely to interfere with spontaneous thrombolysis, and indeed plasminogen also affects other biological activities such as TGF, and therefore may have other biological effects. We are now familiar with the idea that the cutoff for an increase in cardiovascular risk may occur around the 70th to 80th percentile, and people above this level may have an independent cardiovascular risk from their increased LP-a level, and up to this point in time, routine drug therapy has not been particularly successful in addressing this. However, niacin has some utility, and interestingly, recently introduced novel agents seem to also be effective in lowering Lp(a). Therefore, it will become more relevant to measure this entity because now it looks like some treatment options will be available in those people identified as having a problem. The problem with Lp(a) may come from a variety of biological mechanisms. Many of these you would say are equivalent to the atherogenicity of the LDL particle itself, but in addition, the Lp(a) will specifically inhibit plasminogen and interfere with thrombolysis. This protein will also cause it to interact with collagen and proteoglycans in the vessel wall, making it more likely to be retained and oxidized. And its biological activities via TGF-beta may also enhance atheroma formation, may also influence the death and delipidation of macrophages. So plenty of potential for Lp(a) to be more atherogenic than its LDL equivalent. This slide shows the phenomenon of the increase in risk of cardiovascular disease in the form of non-fatal MI and coronary death occurring beyond a level of around about 300 milligrams per deciliter, which would comprise the 70th to 80th percentile. And this increase in cardiovascular risk persists after adjustment for standard risk factors, most notably the lipoprotein risk factors. So it would appear to be an independent risk factor for cardiovascular disease. And it is further confirmed as an independent risk factor by the technique of Mendelian randomization. In this technique, both there is concordance between the cardiovascular risk associated with increased plasma levels and also increased risk associated with a genetic pattern which would predict increased plasma levels. And so this is confirming the likelihood of a causative relationship between increased Lp(a) and cardiovascular risk. If we continue to consider the non-routine lipoprotein and lipid tests, we can think of a handful of electrophoretic techniques which are used for cardiovascular disease assessment. These have been used for a very sustained period of time. They were one of the earliest investigations, and they form the basis of the Friedrichsen classification, or WHO classification, for hyperlipidemia, and this was traditionally generated from electrophoresis on support media such as agarose, and it was possible to identify which particular lipoprotein class was accumulating. However, most of that information can usually be inferred from just the basic lipid and lipoprotein results. The total of cholesterol, triglyceride and HDL are usually enough to infer which particular lipoproteins might be accumulating, and the electrophoretic pattern itself doesn't really tell us much about the etiology or the risk of future cardiovascular events. So there's been more of an emphasis on trying to add clinical information which would lead to the recognition of the etiology of that particular dyslipidemic pattern and the likelihood of it being a single gene disorder or a particular clinical syndrome. And so the presence of elevated chylomicrons alone would infer that we are dealing with a lipoprotein lipase deficiency. The presence of a broad beta band of remnant lipoproteins would suggest that we're dealing with ApoE2, E2 homozygosity, and so the emphasis is lying more towards the identification of these particular syndromes, and that leaves us with the difficulty that just the WHO classification method may not distinguish between two situations where the pattern is similar but the degree of risk is quite different. And so in the pattern of pure elevation of beta lipoproteins, that could be a polygenic cause which would constitute some degree of cardiovascular risk, but the pattern wouldn't distinguish it from familial hypercholesterolemia, in which the risk is very much more substantially increased. And so the emphasis nowadays is to try to identify the clinical syndromes and to quantify their severity, and this will often hinge on other measurements such as LDL, quantitative LDL, non-HDL cholesterol, or most importantly ApoB. And here you see an algorithm in which ApoB, triglyceride and cholesterol are used for the prediction of which lipoprotein classes are accumulating, and then using that as a prompt to consider which particular syndrome of dyslipidemia may be present. And you can see under LDL I've highlighted the possibility of familial hypercholesterolemia or its variants due to mutations of ApoB or the PCSK9 gene, where these represent particularly high-risk situations. And so when we use this approach to try to identify single gene abnormalities as causes of primary dyslipidemia, it's here that we might have other non-routine tests that are required to back up the diagnosis. This is where we might need to measure lipoprotein lipase activity to diagnose its absence, where we might need to do isoelectric focusing to try to visualize ApoC2, which may be deficient, causing a similar sort of syndrome. I've mentioned the genetic mutations which could be occurring to cause familial hypercholesterolemia. We might also look at the gene pattern for ApoE phenotype or genotype to explain the presence of remnant particles, or alternatively we might need to measure hepatic lipase activity for that. And so there are a number of sophisticated protein and molecular techniques which might be required to generate the final diagnosis. Out of all of those potential diagnoses, I'd like to spend a little bit of time just emphasizing the importance of familial hypercholesterolemia, because this is the most common potentially fatal genetic condition with a prevalence between 1 in 250 and 1 in 500. It constitutes a dominant mutation affecting LDL receptor activity, either through the LDL receptor gene or through its ligand ApoB, or through fine-tuning chaperones such as PCSK9. It leads to an increase in LDL, which accelerates cardiovascular disease by about 20 to 40 years. And unfortunately, it's poorly diagnosed, particularly in countries that lack a public health campaign based on what's known as family cascade screening. So first of all, just to look at what family cascade screening is, this is actually the assessment of first-degree relatives of an affected case. And here you can see tracing down a family tree that with a dominant condition like this, that we end up with about 50% of relatives being affected. And an example of the efficiency of this sort of an approach is that a program in the UK screened 200 relatives and in the process detected 121 cases. And to do that by a broad population screening program, you would have needed to screen around 60,000 members of the general population. The experience in Holland, where this approach is widely used, is that within 4 years, testing the relatives in an index case usually yields an average of 8 new cases, and of course 8 other people could be reassured that they don't have a problem with familial hypercholesterolemia. So this is an important public health issue. The risks are accumulating from birth. There's evidence that patients with the condition get cardiovascular disease subclinically before puberty. eventually it accounts for at least 5% of premature cardiovascular disease, and if untreated, 50% of men with this condition will develop clinical cardiovascular disease by age 50. The treatment and management is highly cost effective, so this is a field where we need to improve the synergy between population health and molecular genetics. And the comment's been made that a few specialised nurses, genetic field workers, etc., working in close collaboration with clinicians could work miracles. Just to confirm the argument that this condition accelerates cardiovascular disease by around about 20 to 40 years if we compare men with and without, sorry, that should be there, men with and without FH. You can see that on the horizontal axis they're separated by around about 20 to 40 years, and the same is true of women with and without familial hypercholesterolemia, again separated by 20 to 40 years. As I said before, the treatment is highly effective. There's no dedicated trial for this, but if you amalgamate patients in individual trials, you can get the impression of around about a 76% reduction in cardiovascular event rates, and that this becomes cost-effective, actually cost-saving after about 4 to 5 years. And so best practice involves that strategy of family cascade screening, which is conducted in countries like Holland, UK, Norway, etc. And it largely commences with the identification of an index case, the first member of a family identified with the condition, and this can be assisted by clinical tools such as the Dutch Lipid Clinic score, illustrated for you in the right-hand panel there. Countries who are applying this approach have detected between 20 and 70% of the affected individuals in their populations, and then they can treat them with evidence-based, cost-effective guidelines. And I think the main message out of this is that genetic techniques are used in this setting, but the genetic techniques are more a tool for assisting family cascade screening rather than representing a definitive diagnostic test for a single individual. And so the genetic techniques here should be regarded as a tool rather than as a test. Unfortunately, many other countries, and where I live in Australia would be an example, and I think it's probably fairly similar in the US, that we haven't applied family cascade screening as a widely used health strategy, and therefore detection rates are down around 5% or less. And this is tragic because you can see that there's evidence that cardiovascular disease does start in childhood, and here you see an illustration of the rate of increase in thickening of the carotid arteries in young children with FH compared to the rate of progression in the general population. And so the US has actually approached this by having an alternative strategy, and so in the US the guidelines are for universal screening of children, and I'm not sure if it's widely appreciated, but the strategy here was particularly to address not only the metabolic consequences of childhood obesity, which is such a problem, but also as a widespread method for trying to detect children with FH and bring them into management in a timely fashion. One of the initiatives that can be helpful at a national level is the consideration of using pathology reports to flag very high levels. You might think of a cholesterol greater than 7.5 millimoles or 300 milligrams per deciliter, although it would be more appropriate to use non-confounded measures such as LDL cholesterol or non-HDL cholesterol. But if we flag those results, maybe we can direct clinicians towards diagnostic tools and do a better job of detecting index cases. Again, just now moving back to other forms of electrophoresis, we talked about electrophoresis for diagnostic reasons. Electrophoresis is also used as a gradient gel technique for sizing LDL particles, and you'd be familiar with the so-called pattern A, pattern B assessment of LDL particle size. Measurement of LDL particle size may give the impression of a quantitative result, but really it is a qualitative result, because although it's telling us particle diameter, it's not telling us particle number. And as I stressed before, the main issue as far as atherogenicity is particle number. I think it's worthwhile recognising that issues to do with LDL particle size, LDL density, etc., are largely driven by triglyceride. And we've highlighted the role of cholesterol ester transfer protein before, but you'll appreciate that it's really the amount of triglyceride present in terms of triglyceride-rich lipoproteins like VLDL, which drive the lipid exchange, which removes the cholesterol from LDL and HDL, and which replaces it with triglyceride, which is then consumed, leading to the action of lipase to generate a small, dense LDL particle. So a two-step process where the cholesterol is exchanged for triglyceride and the triglyceride is removed. And therefore, we might mainly expect to see small, dense LDL particles in patients in whom the triglyceride level is elevated. This means that there would be a question as to the value of doing LDL particle size in situations where triglyceride elevation is not present. And in many ways, LDL particle size may just represent a surrogate for triglyceride, and the relationship between LDL particle size and triglyceride is particularly strong if you look at the postprandial triglyceride levels as a predictor of LDL particle size. Again, with non-routine testing and thinking about triglyceride-related issues, one of the more sophisticated tests we could do, and which we have done in the past, would be the use of gas chromatography for the actual assessment of the fatty acid composition of the lipids, particularly triglyceride or phospholipids in membranes, which are present in biological samples. This hinges particularly, I think, on the assessment of the amount of so-called omega-3 fatty acid present. It is looking at the role of individual fatty acids, not so much as macronutrients, but more as micronutrients in the form of essential fatty acids. The N6 and N3 or omega-6, omega-3 fatty acids are essential for formation of membrane phospholipids, and therefore this can be assessed in terms of the fatty acid composition of any tissue you like, and the tissue will determine the time integral over which it's a reflection of the dietary intake of those particular fatty acids. So a red cell, a bit like an HbA1c, would represent a 3-month integral of the fatty acid pattern for that individual, and the amount of the individual fatty acid compared to the total fatty acid composition would give you a marker of its relative enrichment. And so this has been employed in what's known as the omega-3 index, looking at the percentage of omega-3 fatty acids in the red cell membrane. And with interest in the possibility of omega-3 fatty acids, particularly marine omega-3 fatty acids, as having a protective role in cardiovascular disease, this technique can show that patient groups with low levels of protective fatty acids would appear to be more at risk of cardiovascular disease than those after intervention who have higher levels. And indeed, just a range between a low level at 3.3% of fatty acids and a high level at nearly twice that, 6.6% of fatty acids, would describe a change in the risk of cardiac arrest of something like a tenfold difference, and so a 90% risk reduction potentially associated with the difference in the red cell fatty acid composition between these two groups. And if we look on a population basis, here we have the cutoff for probably an increase in risk, and it would seem that in non-supplemented individuals on a Western diet, the prevalence of problems is of the order of around about 50%, just under 50%. So this could be a potentially useful test in the setting of the general population. At the moment, we're conducting fish oil trials where individuals are treated irrespective of their omega-3 status. A question arises as to whether or not better targeting of treatment through the use of the omega-3 index might yield better results. I'll just conclude now by pointing out that there are some rarer lipid disorders, some of which actually involve low levels of lipoproteins. Low levels of HDL, of course, could be a problem. These conditions, although rare, are extremely informative. Quite a few of them have led to the development of actual treatment modalities, and of course their investigation requires very sophisticated techniques using protein chemistry, molecular techniques, mass spectroscopy, genetic techniques, etc., etc. However, those techniques have beneficial yield when looked in the clinical population because they have generated useful treatment options. So I'll just conclude by summarising in a number of areas. As far as total cholesterol is concerned, it's one of the components of absolute risk assessment, but taken in isolation, it's confounded with respect to cardiovascular risk because it's comprised of both anti- and pro-atherogenic lipoproteins. It's a starting point for calculations that aim to quantitate the amount of atherogenic lipoproteins, particularly LDL cholesterol, which may be being phased out, and non-HDL cholesterol, which may be a useful replacement. HDL cholesterol, we're probably looking at now more in terms of functional aspects, but we're not quite sure how we'll test that. The direct methods, which are widely used at the moment, rely on selective recognition, and we need to remain attentive as far as this is concerned. There may have been some interferences with the early generations of these tests. And postprandial testing of HDL, there is a small decrease that occurs postprandially, and we probably need to assess the degree to which fasting should or should not be employed for HDL measurement. Fasting triglyceride standardises the calculation of LDL cholesterol and defines levels for diagnosis and treatment of hypertriglyceridemia, but it's a less sensitive marker of cardiovascular disease and mortality than postprandial levels. Any form of triglyceride elevation, either fasting or postprandial, may influence LDL composition, size, density, etc. And this is also reflected in the inverse relationship between triglyceride and HDL cholesterol. As a summary, the non-fasting lipid and lipoprotein testing may better reflect predominant metabolic state, may better reflect the atherogenicity of the postprandial state. It may be sufficient to provide the total and HDL cholesterol needed for absolute risk assessment. It may be sufficient to calculate the non-HDL cholesterol, which is becoming preferable over LDL cholesterol, and it may facilitate patient management, given that it's more convenient for a patient just to provide a sample at any time of day rather than having to present after a 12-hour fast, presumably in the morning. And so the most widely non-routine tests can provide potentially useful information. I think the apolipoprotein measurements, which are most relevant to bring into more widespread use, would be measurement of ApoB and lipoprotein A. And other non-routine tests, we're particularly looking for those tests which will give us quantitative information, and this tends not to be available through electrophoretic testing methods. It's important to recognise clinical features that identify causes of primary dyslipidemia. Recognising the features of familial hypercholesterolemia is particularly important, and therefore we should think about flagging very high levels of total, or more particularly non-HDL or LDL cholesterol levels, directing people towards diagnostic tools such as the Dutch Lipid Clinic score, and pursuing strategies such as family cascade screening with or without genetic testing. The rarer causes of dyslipidemia have led to important treatment discoveries, and they require sophisticated laboratory methods. One test with demonstrated clinical utility is the omega-3 index, and probably most significantly, reliance on LDL cholesterol as a diagnostic treatment threshold or treatment target is likely to diminish, and a plausible replacement, something that's simple and practical, would be non-HDL cholesterol, which is simply the difference between total and HDL cholesterol, and it's already been demonstrated that this has better clinical performance. So thank you very much for sticking with us. I'll just switch on Q&A, but I realise that the hour is up, and I'd be only too pleased to respond to questions now or as they come in the next few days and months. Thank you very much.